Right, HHS is similar to DKA. Unlike DKA, which happens to type 1 and type 2, HHS can only occur in type 2 diabetics. Okay. The difference here is if you remember the pathophysiology last week, what's the difference between type 1 and type 2 diabetics? Type 1, no insulin, right? What about type 2? Not enough insulin, or there is insulin resistance, right? Okay, so that's the difference between the two. So if we go back to DKA, in this diagram right here, there is lack of insulin. So if we change this to HHS, it won't say lack of insulin. It will be,
No,
you just said that type 1 has no insulin,
No
type 2 has
not enough.
not enough, and there is insulin resistance. So if we change this to HHS, what will this top figure say? Not enough insulin. Okay, so this will say inadequate, okay, instead of lack, right? So because there's only inadequate, will you have ketosis? There's no ketosis in HHS. Okay, so since there's no ketosis, will there be a need for bicarbonate? Because there's no ketosis, so will there be any acidosis? No. But however, on the left side, will these be present? Yes, and the other difference between DKA and HHS is in HHS, what was the trigger again? Why did the blood sugar go up in DKA? What was the underlying precipitating condition? Say last week with Sering, let's say I had type 1 diabetes.
Illness.
All right, so it's the same, right? So I got sick either physically, emotionally, or psychologically, same trigger. And the difference is there's no lack of insulin, there is inadequate insulin. Okay, so inadequate insulin, I did exactly the same thing, or I did not do exactly the same thing, meaning I stopped, I couldn't eat. Okay, I was thinking about staring only, so I stopped checking my sugar, I stopped taking my medicines for diabetes. However, this is occurring, okay, because there's not enough insulin, so the sugar is also still rising. But the right side column here did not occur because I still have enough insulin to prevent ketosis. Okay, so I have enough. I don't have enough, but I have a little bit to prevent ketosis. Okay, but however, unlike DKA, wherein how long did DKA fast, right? Within a few hours. So my sugar, what was the diagnosis of DKA made? What was the blood sugar? 250 or 300, right? I was already in DKA. In HHS, the diagnosis of HHS doesn't start until my sugar reaches 600. So therefore, if my sugar is 600 and higher, who's more dehydrated? Is it the DKA or the HHS patient? The HHS will be more dehydrated. Plus, the onset again. How soon did I develop DKA? A few hours, right? A few hours. I could be fine this morning. Then as soon as Sering broke up with me, I could be in DKA after lunch, right? My sugar will go up that fast. However, in HHS, this will take days because this was, again, we have enough insulin. Okay, there's inadequate insulin, but still enough to keep sugar, low most of for a few hours. But then over this next several days, my sugar will reach 600 or higher. And then I have HHS now. But however, how long was I exposed to dehydration? Because did my sugar go from 70 to now 600? Or did it go up 200, 250, 300, 301, 320 until I reach 600 in 3 days or 5 days? Well, very slow over several days. So did I notice the changes? Were the changes acute? No, they occurred over several days. So I'm not as, plus is there ketosis here? So will I have Kussmaul's? There's no Kussmaul's here. So therefore, no acute symptoms, right? Unlike in DKA, wherein you saw a Kussmaul's. This one, no Kussmaul's. And look at the manifestations. Oh, here's a side-by-side comparison, by the way. 46, I forgot about this. So table 46-6, say here. So DKA type 1 or type 2, however, in HHS, mostly type 2. It can occur in type 1, but very, very rare. Okay, mostly type 2 HHS. Again, same precipitating events. Onset, look at this. So onset, few hours for DKA, several days for HHS. So therefore, how long was the patient exposed to hyperglycemic, hyperosmolar, and osmotic diuresis? Over several days as well. And the higher the sugar, the more osmotic diuresis occurs, then the more dehydrated the patient. Look at this, 250. Now, don't get this wrong. This table simply says that DKA patient starts at over 250. Does not mean it's not going to reach 600 or 1000. Does that make sense? Did I make that clear? Okay, so meaning it just starts at 251 or higher. Doesn't mean you won't reach 1000. Is that clear? All right. Both patients, will they have AKI? Yes, both patients will have severe dehydration. In fact, HHS patients will have higher blood sugar, so they are more dehydrated. Therefore, their AKI will be more severe compared to DKA patients. Look at the mortality. Which one will likely die more, DKA or HHS? HHS has a higher mortality because, again, the symptoms. Let's look at the manifestations. If you have these symptoms, especially altered level of consciousness, again, no respiratory symptoms, no Kussmaul's aspiration, what will this patient have? Let's say they live alone and they have altered level of consciousness. Will they have the mental status to pick up a phone and call somebody? So what will you do if you have altered level of consciousness? Who knows what you're doing, right? Then you're already very dehydrated and you have no idea what's going on. So these patients will probably just lay down in bed. The problem is they probably won't wake up. All right. The next thing you know, you haven't seen them for a week. You go visit them. Yeah, they're already smelling. Okay. They're already decaying. Diagnostics, no different from DKA. We'll draw the same blood tests. We'll look for, again, these will be the differentiating factor. Obviously, the DKA patient will have low pH, but look at the pH level in HHS. It's normal or it may be a little basic, but usually they have normal because, again, there's no acidosis, there's no ketone bodies, there's no fat breakdown. Management, it's really the same as DKA. Because are they hyperglycemic too? Yes. Higher or the same as DKA? Higher. So how much more insulin will they require? More insulin. So who's more dehydrated again? HHS. So who will get more fluids? HHS. Okay. However, unlike DKA has acidosis, therefore may require bicarbonate if the patient's if the patient's pH levels is severely low, 7 or less. Will these patients ever require bicarbonate? No, because there is no acidosis in HHS. And if you read the rest and then compare it with DKA, it's really the same. So you monitor blood sugar every 15 minutes. So that's the frequency. If you have a continuous insulin drip, okay, you have to check, because what's the danger of a continuous insulin drip? Hypoglycemia. So if you check it only every 4 hours, what could happen to this patient? Hypoglycemic. Okay, so therefore, if there's an insulin drip going, every 15 minutes you draw blood. You prick a finger, draw blood. Okay, test the sugar. So who will stay in the hospital longer? HHS again. So if I change the patient next week from DKA to HHS, will you do anything different? Expect more fluids and higher insulin dose order. All right. Any questions on HHS? That's it.